Yeah, this title, From Theory to Practice in My Personal Algorithm, this is really difficult to find an algorithm in treating dialysis access, whether which kind of access we create and how we treat dialysis access. Here's my slide of my disclosures. And we've heard excellent presentations by the two previous speakers. And one thing that we know is that the dialysis access requires maintenance procedures more commonly than we actually wish for our patients. And in general, and also for me, the balloon angioplasty is a first-line option for treating stenosis in dialysis access. But we know that there are some disadvantages of balloon angioplasty, also such as the rupture of neointimal hyperplasia layer, which can increase the injury and also increase the damage, hence also increase the risk of more extensive neointimal hyperplasia and stenosis. Also, we know and we heard that the incidence of recurrence is high, especially within the 6 months. This is some kind of an endpoint for any kind of interventions, which is not a satisfying endpoint with 6 months. And we also heard and we also know that drug-coated balloons seem to increase the time from one intervention to another intervention. And we hope that maybe with increased numbers of types of the balloons, maybe in some kind of different anatomical locations, and like Dr. Kitru said, types of stenosis, which I also don't really manage to figure out which kind of stenosis this is. Maybe different balloons will play a different role. And we know that there are different types of balloons to treat a lesion using balloon angioplasty. Several types of non-compliant, high-pressure, ultra-high-pressure balloons, also scoring balloons, cutting balloons, and also there are different types of drug-coated balloons. And the Perda balloon is a high-pressure drug-coated balloon with its differences to treat dialysis access. As you can also read in a brochure of the balloon, if you're interested on their website. So it has the paclitaxel covered on it, and it is an anti-inflammatory and anti-proliferative effect. And actually, when I was thinking about using the Perda balloon, I always try to figure out what novel device or procedure or technique we can apply to our patients to extend the life of their dialysis access, to reduce the reintervention rates without higher risks of those procedures. And then the costs, of course, come at the end, are also important. But then when I saw that there was evidence behind this balloon actually in dialysis access, this triggered my interest in trying the Perda balloon also in my patients. And this is an RCT, and we already heard the experience of Dr. Tozzi with his extensive registry from Italy, now reaching 600 patients. So that was actually an interest of me to try the balloon. There was also an interest to see whether the balloon itself can change the outcomes of the patients based on the pressure, because we know that good vessel preparation is something that our dialysis accesses require prior to drug-coated balloon application, because the drug-coated balloon is not intended to treat the stenosis, but to extend the patency rate, the target lesion patency rate with the DCB, with its drug. But the question was also, which interested me, whether the Perda balloon with its high pressure can be used as 2-in-1, basically using the high pressure of this balloon to crack the lesion, to completely extend the lesion, and simultaneously apply the drug. One of the reasons was also, like Dr. Kitru said, when we use a drug-coated balloon, we should extend the balloon longer than the angioplasty balloon we use for vessel preparation. Hence, we create probably, maybe, I'm not sure, more damage to the lesion or to the healthy vessel outside of it, because we see that the recurrent stenosis might be longer and heavier in the patients. So this was an interest of me to use one balloon as an angioplasty balloon, and I started using this balloon back in September last year. And I'm routinely using the DCB since a couple of years in over 80 to 90% of cases. And up as of today, we have done it in 27 patients, and quarter of it were female patients, and most of the patients were using the dialysis access for either hemodialysis or apheresis, and the typical demographics such as 67 years old patients, in average from 36 to 88. So basically sporadically trying to figure out where to use it, and also in which kind of dialysis accesses to use and in which locations to use. So we have 2/3 of the patients who had previous interventions and 1/3, almost 1/3, who didn't have any interventions. 37%, it should be not 27, sorry. And also we had patients with previous angioplasties reaching from 0 to 6, so 1.7 interventions previously. And as you can see, there are diverse types of dialysis access. We use it. So basically in every dialysis access we create here, starting from the snuff box and radiocephalic fistulas, also percutaneous AV fistulas and the surgical grafts fistulas, proximal forearm, also arteriovenous grafts. And 63% of those lesions are actually juxtaanastomotic stenosis, which are known to be one of the main issues at forearm fistulas and also for endovascular AV fistulas. And we have also treated graft venous anastomotic stenosis in 15% of patients. And why is graft venous anastomotic stenosis interesting? Well, because we know that the stent grafts seem to gain more interest in treating graft venous anastomosis stenosis because of its significantly better patency rates rather than the angioplasty. So the thought was maybe we could avoid using stent grafts in those lesions if we can treat those lesions better with an angioplasty and a drug-coated balloon, hence the aperta balloon. And the procedure success with 96%, why is it 96%? Because one patient had a significant recall after the intervention and we had to use stent to cover it. So that's why I decided to use it as a technically not successful angioplasty in this case regarding the balloon. And actually in 63% of those patients, we just used the aperta balloon without a previous vessel preparation, whether it was an angioplasty or another device. So that was something interesting to see how aperta performs as a standalone device, because I think that if it also proves to be efficient, at least as efficient, if not better, then we also spare costs on another device using prior to that. So when you look at this slide, of course we have limited experience. We have mean of like almost half a year experience, ranging up to 252 or now already 253 days. And we have primary access circuit patency of 85% at 141 days. We have assisted circuit patency of 92.6%, and we have 96% of secondary patency rates for those accesses. And if you look into the last one, this is the freedom of target lesion patency reintervention. So it is 89% at almost 6 months. So it looks like the number of 89% at average 6 months is a good number, comparing it with the literature, with other experiences. And as Dr. Kitro mentioned about the publication on percutaneous AV fistulas and angioplasties, there are 5 of those patients that we treated with a aperta balloon had juxtaanastomotic stenosis in percutaneous AV fistula, in an ellipsis fistula. And as you can see, up to 252 days, all of them had 100% primary target lesion patency rate. Also, those 3 patients with graft venous anastomosis stenosis had also 100% of primary target lesion patency rates up to 154 days, so half a year. And only 3 of those 27 patients had primary target lesion patency loss because one access was occluded and was abandoned due to another location, but still the access was lost. And there were 2 reinterventions at the same location at 72 and 238 days, which kind of shows that it looks like this balloon does very well. Now, I would like to show you a couple of cases. This one is a young patient. She's a female patient with end-stage kidney disease, and she had 3 different dialysis accesses already over 6 years, starting with a snuff box AV fistula and then proximalizing it to radiocephalic fistula. Eventually, when that vein was completely destroyed, there was an forearm radial artery to upper arm distal basilic vein straight AV graft placed, and this patient was referred with a graft venous anastomosis stenosis, which led to 300, almost 300 flow, so it was a dysfunctional dialysis access. So this was the first time intervention at this lesion. There was a sonographic image showing this graft venous anastomosis stenosis. As you can see on the right side, the dialysis unit said she has 300 flow. We measured 565, as you can see on the left image. So it's a little bit different in dialysis access flow measurements. But on the right side, you can see this tight stenosis with 1.4 millimeter at the vein right across the graft venous anastomosis. So the idea was to treat it with only with an aperta balloon without previous vessel preparation. You can see we used ultrasound guided technique. We wired the stenosis all crossed it over, used the balloon to do an angioplasty. This is an 8 millimeter aperta balloon, which slowly inflated, and at 18 atmospheres reaches complete inflation, which we of course keep for 3 minutes and above. We do an extended prolonged angioplasty in general, but using DCB, of course, 3 minutes is our time. And then after the procedure, you can see clearly how the stenosis looks with an ultrasound, with color flow and also without it. And interestingly, this patient actually jumped from 500 to 2.3 liters flow. So we are monitoring her because this patient actually had a previous flow reduction procedure as a bending at the anastomosis. And because of some problems with dialysis, another surgical unit decided to remove that banding and created a patchplasty at that region where the banding was. So this treatment led again to an increase of flow. So we're going to reduce it if it stays high enough. But she's stable, so we're still monitoring her. It's a half year already. The second patient, also a patient with a graft. This is a male patient, slightly older, 51 years old. He had a previous brachial basilic fistula, and then it was converted very early to forearm AV graft loop, which was then replaced because the graft was completely destroyed in 22. There was an external surgery revision with patchplasty of both anastomosis, and then another revision of that patchplasties, so it was treated with a stent graft, and then simultaneously the outflow brachial vein was treated with an angioplasty as for now 2 years ago. So then there was a patch infection, somebody replaced partially the graft, so now the patient was referred with an outflow brachial vein stenosis and dysfunction. So this was his second intervention at the same location. And as you can see on the left image, the small one is the old graft, and the big one on the left side, the outer curvature, is the new graft. And on the right side, at the top, you can see the stenosis in the outflow vein. There was also some stenosis or some wall changes in the graft close to the stent graft at the graft venous anastomosis. So again, in this case, ultrasound-guided procedure. Here's the stenosis in the outflow brachial vein on the left side. On the right side, this is the B-flow, which helps you to see the flow differences in the graft, where you have slightly but not completely echogenic changes in the graft wall. And then this is the 8 millimeter aperta balloon, 8x40s. Also no previous vessel preparation, single balloon. Inflation at 14 atmospheres, the balloon was completely inflated. Again, 3 minutes inflation time. We also used the balloon to dilate the changes in the graft. So you can see on the left side how the vein looked after the angioplasty. It reached almost 6 millimeter in diameter. And on the right side, that's the graft after the angioplasty. And the flow was increased to 1,400 cc's per minute. I think the example of the AV grafts is really interesting. Again, like I mentioned before, that the stent grafts seem to take over as primary, even in most cases, primary treatment of graft venous anastomosis stenosis by endovascular means. And this, of course, little group, small group, short experience, but this can also show that an angioplasty can be effective in treating graft venous anastomosis stenosis. And also, if you don't cover it, and probably or possibly extend another lesion at the edge stenosis of a stent graft, you will have a new venous anastomotic location for another graft down the road in the future if the patients need another graft. So you will not completely cover the outflow vein over the time if you require it. Just to shortly show you this is a video. This is an outflow vein, basilic vein stenosis in a patient with a native fistula. And this, as you can see, there's the stenosis in the upper arm basilic vein, where we used ultrasound guidance to go over with a wire. So I think that in this case, it is interesting to see how this again 8 times 40 millimeters balloon behaves. Again, ultrasound guided procedure. This is the aperta balloon covering the lesion, proximal and distal, and then we used to use slow inflation and also slow deflation to avoid recall and rupture. So this is this 8 millimeter balloon in this high-grade stenosis. This patient had almost functional occlusion of this graft or his AV fistula with a flow less than 200 milliliters per minute in the brachial artery. So in this case, the slow inflation over several, like 10, 15 seconds, 2 to 4 atmospheres. This is how I like to do it. And under the ultrasound, this gives you a visual example when the balloon completely inflates, how to deflate it. Is there a hematoma around it? Is there a recoil instantly around it, or maybe later on? And you can see that the balloon is already opening up and there is still some waste left at the middle, but still due to this balloon can reach up to 18 to 20 atmospheres. So you have the time to open up the lesion, like here you see, and then simultaneously apply the drug. This was 10 atmospheres, and this lesion was already completely open. With that, I would like to thank the guys from CardioNovum for inviting me and for all the participants for being part of this webinar. Thank you.